Please join us weekly for the 12th District with yours truly, Kerry Condata. Check your channel guide for times or go to ncwlife.com for details.
Welcome to Let's Learn here on the NCW Life channel. I'm Eric Grandstrom, your host, and on this series of topics regarding death and dying, we continue to talk about, well, trying to plan ahead. It was Marcus Aurelius who said it, the art of dying is one of the acts of life. And it's a conversation that nobody really wants to have, but we're having it here in Let's Learn because it's a non-emotional, non-charged environment and trying to get a little bit more information so that you can be armed about trying to make decisions on your future or your family's future. So on this episode, we're going to talk palliative care. And we have a couple of folks from Central Washington Hospital and Confluence Health to help us with that. To my far left, we have Dr. Charles McCormick, who's the palliative care physician for Confluence Health and Central Washington Hospital. Welcome.
Thank you very much.
We also have Megan Collyer, who is the inpatient palliative care coordinator at Confluence Health.
Hi.
Hi. Thanks for coming and
Thanks
joining
for
us here
having
today.
us.
Let's first talk about you guys and how you got into this field of endeavor. First of all, Dr. McCormick, you haven't been with the hospital very long, have you?
No, I've been out here for about 3 months now. So I am originally from West Virginia. I was trained as a family physician and from there went mostly into geriatrics, long-term care, nursing home practice, and that was a natural progression to hospice and palliative care. So in West Virginia, I had about 15 years of experience as a hospice medical director and palliative care physician at the local hospital. We moved our family down to South Carolina. I practiced palliative medicine and geriatrics there. The attraction of Wenatchee was the opportunity to practice 100% palliative care.
Mm-hmm. That progression for you of going from family physician to that, was that just felt natural to you? Was that something that it was a conscious choice? It was just kind of you gravitated that way, or how did that happen for you?
You know, when you look back on it, you wonder exactly how that happened. You know, as a family physician, we would say we took care of people from the cradle to the grave. And I seemed to move towards older patients initially, you know, and then really felt that providing patients good symptom control at end of life was a very gratifying practice for me. So I do feel like it kind of I just moved in that direction almost unconsciously, and happy to be where I'm at right now.
Well, welcome to you and your family to North Central Washington.
Thank you.
So, Megan, how did you get to where you are with the hospital, and how long have you been doing that now?
So I've been at Confluence Health for about 3 years or so. I started doing general medical social work on the floor, and then gravitated towards palliative care when I was able to sit in on some of the palliative care consults at the hospital, and I was just instantly attracted to being a part of those individuals' lives at that stage in their life. And so when the opportunity arose for me to be able to be a part of the team, I jumped on it, and I've been there for just going on 2 years.
Okay. So we've had Dr. Voorhees in, we've had Michelle Church in to talk about hospice care, which I guess is a form of palliative care. Is that correct?
Yes, hospice is palliative care when a physician says that this disease has less than 6-month life expectancy. So it really is a comprehensive insurance benefit, initially through Medicare, and now many other insurance programs cover it. But it is palliative care in an interdisciplinary way, covered by an insurance program when you have an estimated life expectancy of 6 months or less.
Okay. So broadly speaking, palliative care is what then?
Palliative care is appropriate at any point in a serious illness. For instance, someone with congestive heart failure who has an exacerbation and doesn't seem to come back to where they were before, any change in that health status, palliative care would be appropriate to evaluate them at that point in time. You know, certainly cancer patients who may be wanting to pursue active treatment and may not be appropriate for hospice care still have symptoms, still have pain, still get short of breath and are nauseous. Those people are appropriate for palliative care. And then when you have those patients that the healthcare system is very confusing at times. We do a lot of things to patients. Some of them, most of them, we hope are very good. But sometimes patients and families get into that healthcare system and feel almost lost and feel like they've even lost their ability to make the decision that is right for them. Palliative care is there to help those families and help those patients understand their disease process and try to choose a course of therapy that is consistent with how they lived their life and what their goals are.
So is there a difference between, okay, we're still fighting whatever it is, not quite palliative, or is palliative, okay, we've been fighting it a long time, you know, we're kind of, okay, it's about quality of life now?
Well, we would say that it's always about quality of life. So even if you are still fighting whatever illness you have, we want you to fight it with the best quality of life, with the best symptom control, meaning you have the least amount of pain, you have the least amount of shortness of breath, you're not nauseous. And so we encourage you to pursue any treatment that you want that's consistent with your goals, consistent with how you lived your life. We just don't want you to feel horrible while you pursue those goals.
Sure. And I suppose the social work on that element that the doctor talked about as far as getting lost in that machinery, and that's where you come in?
Yeah, I mean, you know, the healthcare system is a complicated system for people who do this for a living. So it's almost impossible for us to expect people to be able to navigate through this system alone. And like Dr. McCormick said, a lot of what we do is try to elicit patients' stories, who they are as individuals, make sure that the healthcare plan that they are putting in place makes sense to them and what's important to them. The big social work part of it is making sure they have the support they need going forward, whether that's home or in a facility, and making sure that they also have emotional, spiritual, social support going forward as well.
And that's something that's interesting about this conversation too, is because going into it and talking about death and dying, you know, there's the whole element of spirituality that I kind of wanted to not get into, but you can't help but get into that in some form or another when you're talking about somebody's last days on this earth.
Sure. You know, when we're looking at palliative care and just medical care in general, you really want to take a look at that whole person. So not just the physical symptoms that they're showing, but their spiritual symptoms. And when people are facing chronic and terminal at time illness, it's important to address all of those aspects as well.
Well, we're going to dive into a little bit more of this as we continue here with our Death and Dying series talking about palliative care. We'll have more right after this.
Stay up to date with what's happening in North Central Washington. Go to the NCW Life Community Calendar at ncwlife.com.
Welcome back to Let's Learn here on the NCW Life channel. I'm Eric Granstrom, and on our series of topic regarding death and dying, we're talking about palliative care. And joining us in studio, we have a couple of folks from Confluence Health and Central Washington Hospital. We have Megan Collyer and Dr. Charles McCormick, and we kind of talked generally speaking about palliative care. I guess let's take a scenario where I have cancer, prostate cancer, something like that, and it got out of control. We've done what we could. At what point do I wind up with you guys? Is it my doctor that refers me to you? How does that work?
Yes, it is. In the hospital, it's a physician referral. If you're in the outpatient setting, again, it's a physician referral. But often the family or the patient themselves will ask their doctor, hey, I'd like to go see palliative care. I've got pain. I'd like to talk about this illness and what it really means to me and my life. And I would also say that it doesn't have to be that there's really nothing else to do for the cancer or things have gone bad. The earlier palliative care is involved in someone's illness, the better results our studies have shown. So, there's better quality of life, there's less depression, there's better symptom control. People may not go to the hospital as much with early intervention from palliative care. So we would say that at any point in a serious diagnosis, palliative care could be involved. So it would be appropriate on the day or the week that you're diagnosed with prostate cancer to come and have a talk with the palliative care specialist.
Okay. So Megan, what does that conversation, does it start with you and then it gets to Dr. McCormick after that, or how does that flow?
In the outpatient setting, like Dr. McCormick said, that's when people are managing their illness and getting extra support through that process. When people are seeing me on the inpatient side of things, sometimes there's a change in their health, maybe things aren't going as well. So sometimes a conversation on the inpatient side might feel a little different than on the outpatient side. The goals remain the same, to make sure patient symptoms are well managed, and that we really understand the patient's goals of care progressing forward with their illness. Dr. McCormick and I tend to see most patients together initially. That's because we bring different things to the table and want to make sure that we're addressing that whole person. So we do it together as a team.
And that was my exact word I was going to use. Is it just the patient? Is it the patient and their family? Is it, because it seems to be, if you have a team approach, that we're going to fight whatever it is, not only from the hospital and Confluence Health's perspective, but also from the family's perspective. So how does that dynamic work?
Yeah, we always want to have family and support systems involved in those conversations. People are a lot more than just themselves as individuals. They're their loved ones and their belief systems and their family structures, and it's important to have all of those important people at the table when they're having those conversations.
Now, you have someone else for us to talk to at a future episode regarding outpatient palliative care, correct?
Yeah. Her name's Jenny Heinitz.
Okay.
She's the outpatient palliative care coordinator for Confluence Health, and she's a huge wealth of knowledge. And
so what I learned about hospice care is that it's not actual medicine administration for hospice care. There may be, but that's not the job of nurses or somebody that comes in like the home setting for hospice care. Palliative care sounds like it is part of that overall thing?
Well, with hospice, there's often a lot of medications involved. But the nurse particularly is not necessarily administering those meds. She's making sure they're taken correctly, but the family is responsible for all that. Palliative care in the outpatient setting, similar thing. In the inpatient setting, their disease is usually further advanced. They may actually pass away in the hospital. And so we will be using medications in different routes instead of oral often. Often our patients are on IV medications to control their pain or their shortness of breath or their nausea. And family involvement is crucial. If they're going to be going home, again, our patients in the hospital generally are so much sicker and so much more debilitated that we need the family to help care for them.
I assume that sometimes the conversation might only happen with the family member if they're that sick, right?
yeah, we do have, there's instances where the patients are no longer able to verbally communicate with us. And so we're really depending on those families to act as that individual's voice.
So I guess that goes back to this conversation that we'll also continue with further episodes regarding making plans so that you do have a voice for you if you don't have your own.
It is really important that you have designated someone to make decisions for you in the event that you cannot make those decisions. And it's great to try to let people know all the different scenarios that may happen to you, but the best thing is that someone knows you and knows how you would want to live your life to make those decisions for you.
I imagine it's got to be difficult with whatever the ailment may be that the patient is battling from your perspective, because whatever that illness is not who they are, it's something they have. And treating, as I've heard now from Confluence Health several times with the folks we've had in already, about a holistic approach, and we kind of talked about the spiritual side and taking a look at the whole patient. Dealing with them in that regard and making them feel like they're a human being and not this illness, that cancer is not the thing in front of me, I am the thing in front of it. I imagine that's got to be pretty important in this whole process.
You know, the patient story is the process, right? So as patients' illness continues to progress, their goals are going to change. What's important to me at early diagnosis, as you said, may be different when that disease process continues. So I think a good part and a really vital part of palliative care is to normalize conversations around this with their loved ones and with their family members. So that story comes out throughout that process.
How do you do that?
We spend time. We spend a lot of time talking to patients. You know, I think sometimes patients are a little taken off guard when we come into the hospital room because we're asking things that they don't normally get asked when they're in the hospital. But it takes time and patience and compassion.
So it's not just how are you feeling today, it's more of how are you?
Tell me about you.
Yeah. That's interesting.
Yeah.
We need to take another quick break. We'll come back and talk more about the palliative care. See, I knew I was going to do that eventually here. On our series of Let's Learn topics here as we talk about death and dying. It's something nobody wants to talk about, but we're going to talk about it right here on Let's Learn on the NCW Life channel. We'll be right back.
Have a fun video you'd like to see featured on NCW Life? Email us at newsphotos@ncwlife.com.
Welcome back to Let's Learn here on the NCW Life channel. I'm Eric Grandstrom, your host. In our series of Death and Dying, we're talking about palliative care today with folks from Central Washington Hospital and Confluence Health. We have Dr. Charles McCormick and Megan Collyer here. I guess the question for me would be, so what are the big questions, or what are the questions you ask of patients when they come to you and land on your doorstep for palliative care?
Sure. You know, I think a lot of times patients don't even know where to begin. That it, like we talked about earlier, it's a confusing healthcare system at times. And a lot of times options are given to them and they just need help navigating through that. So some of the stuff that we do in addition to really trying to understand that person is to figure out what they're willing to tolerate and what they're not willing to tolerate. What would be an unacceptable quality of life for them. So through their story and through having a better understanding of that, we're able to better guide patients through that decision-making process. You know, for someone, being able to play a round of golf is their cutoff point in their in their chronic illness. For others, being able to conversate with their loved ones is a quality of life for them. So every individual is different, their stories are different, so we spend a lot of time talking about that.
Okay. Yeah, a lot of times, whatever the disease might be, especially cancer, it seems that you know, the wage of battle, it has an amazing toll on that individual.
Yes, it does. And one question that is often asked of us in the hospital, again, these are patients that are often in the late stages of their illness, and they want to know how much time they have, or, you know. And we as physicians, we don't like to give up. And we like to tell patients that we are not giving up. We're not stopping treatment. We are redirecting our treatment towards a more comfort-centered approach. So in the late stages of illness, the type of cancer seems to be less important than how they are doing. And by how they are doing, how short of breath they are, how much weight they may have lost, how little they're able to eat. A lot of families say that their loved one is starving because they're not eating with advanced cancer, and we try to tell them that it's advanced cancer and not their starvation that's causing this. They would eat if they could. So when they ask us about how long, we try to reason through those symptoms and then look at how they have declined with their illness over the last months or weeks, and try to give them as good an estimate as possible. The oncologists and their cardiologists, the other specialists, often have great insight into that as well. And so we try to look at their opinions when we're trying to help patients through that.
And that's towards the latter stages. I mean, even before that, no matter what the diagnosis may be, it may also be that question of, okay, what can I expect? What's going to happen to me before you get to those final stages, right?
Yes, and that is often based on how well the patient was doing before. So an early diagnosis of cancer, we should probably be involved, but early in the course of cancer, the type of cancer is more predictive of how well they will do, and more in the oncologist domain of that prediction than it is for us. We want to support them through their cancer treatment and make sure that their symptoms are well controlled through their treatments.
Mm-hmm. As far as the families are concerned, because we talked about how the family is just as important as the patient themselves, with that education process, I mean, it's one thing to say, okay, here, read up. It's another thing to say, you know, here, let's sit down and talk about it. How open is the hospital, how open is your office to have people to come in and obviously make an appointment, but to just sit down and have that conversation, because it's scare you to death to have basically a death certificate waiting for you, and now you've got a clock ticking.
Yeah, well, the hospital has been tremendously supportive of palliative care. So we could not ask for a better environment to practice what we like to do at Confluence Health. Our door is open for anybody who wants to talk about this. And as we've said before, any stage of a serious illness, palliative care conversations are appropriate.
Mm-hmm. And I guess the big thing to get across to folks, whatever the situation may be, is that whatever you put in front of the word care, it's about care, right?
Yeah. You know, it's really important for, again, I know I sound like a broken record here, but it's important for us to look at whole person care. And that really is our goal with palliative care.
Okay. So how do we reach your office? Is there, I mean, can we go through the general phone number for Santa Washa Hospital?
Sure.
Or how do we do
You
that?
you can call us directly. Our administrative assistant helps coordinate appointments inpatient and outpatient. And do you want the phone number?
Yeah.
Okay.
Please. Yeah.
So you can call 509-630-4042, and our admin assistant will help arrange those appointments.
Okay. All right. Doc, you've been here 3 months now. How do you, this is a general question about Santa Washa Hospital and Confluence Health. I would like to think we're in good hands here in North Central Washington, having that facility here. All right, you're on the inside coming from the outside. What do you think so far?
Well, I think I've been ecstatic to practice here in Wenatchee at Confluence Health. All of the physicians that I work with are of the highest quality, and I've thoroughly enjoyed it so far.
Great. Also, you know, I know that that we don't necessarily pay the best here in North Central Washington. We can't offer, but we do offer those quality of life things. Is that something that brought you and your family here?
It is.
Because we keep hearing that.
Yes.
We keep hearing the hospital say, well,
Yes.
it's about the skiing and it's about the outdoor
It
recreation.
is about
and
the
things
quality
like
of
that.
life, and it's been great, so
Wonderful.
absolutely.
Wonderful. Thank you very much both for
Thanks
joining
for
us here
having us.
today. As we continue our series on death and dying, we will talk with the outpatient person as far as palliative care from Confluence Health in a future episode. Also in future episodes, we will be talking with folks from a memorial chapel. We'll be talking with folks at the cemetery, where you'll finally end up, or where will you end up? Will your ashes be spread somewhere? You know, you have to have a permit for that. We're going to learn all about those things as we continue on here with our series on death and dying on the NCW Life channel. That's going to do it for today's episode. Thank you very much for joining us. That's Let's Learn here on the NCW Life channel. Again, you can find out more information about this series and some of the topics we cover in our website at ncwlife.com. Thanks for watching.
Get the fastest internet available in North Central Washington by switching to LocalTel and get speeds up to 1,000 meg. Call 888-8888 today or go online to localtel.net.